Good morning. So I'm going to talk a little bit about some recent work in our lab, particularly exploring the idea of interferon gamma as a pathogenic driver of some of the lung disease that we've been talking about, which I think will build nicely off of the beautiful work that Adriana and Scott have presented. So as we've sort of talked about with this disease, one of the most striking pathological features we see is this alveolar prognosis. We see this filling in the lungs, in the lung alveoli, with this sort of granular prognaceous material with these sort of very foamy macrophages that look like they're trying to sort of clean it up somehow. And looks similar to this sort of spectrum of diseases that we call PAP, or pulmonary alveolar prognosis, which very broadly are alveolar macrophage problems. So classical PAP looks a little bit different from our disease, but the prominent and pathognomonic feature is this filling of alveolar spaces with protein, and the protein is really surfactant. And PAP can kind of be divided into sort of broad classes. One of them are things that are called congenital PAP, which are genetic problems with surfactant production that were first described by Jeff Whitsitt at Cincinnati, one of my pulmonary mentors. And then there are these disorders called primary PAP, which are caused by disrupted maturation of lung macrophages, alveolar macrophages, through this GM-CSF signaling pathway. And this can be infants and young children with hereditary PAP, where they have problems in the genes that encode the receptor or other related signaling molecules. It can also be caused in adults, which used to be called idiopathic PAP, but it's been actually found out that it's an autoimmune disease where there are autoantibodies against the GM-CSF receptor. And then there's a whole gamish of secondary causes of other things that can cause PAP, which very broadly are things that affect the function or number of alveolar macrophages. So with sort of this, and with our colleagues here who are sort of world experts on PAP, we began to try to examine these patients with lung disease to say, is this something that is really primary or congenital PAP? And the short answer is no. We've not been able to find mutations in genes that are associated with hereditary or congenital PAP. We've also not been able to detect any autoantibodies against the GM-CSF receptor as seen in patients with autoimmune PAP. We then look to see, are there functional problems in the response of monocytes in these children to GM-CSF? It's caused by something that we don't know how to test yet. And the answer is really no. So really they respond indistinguishable to controls to GM-CSF signaling. We then wanted to look at the lungs more carefully to try to understand what we are seeing. So if we compare these children to children with primary PAP, either autoimmune or hereditary, we see similarly in the alveolar spaces, again, a macrophage predominant fluid. However, significantly less of those macrophages are what's sort of scored as lipid laden. So when the pathologists look at these macrophages, they look to see, are they chock full of lipids? And much lower of a degree than we see in those primary PAP, which is why, again, many patients who we've seen have had a bronchoscopy, have been said this is not PAP, and then if they later have a lung biopsy, they see the prognosis on biopsy, but they're not able to mobilize it like we can in primary PAP. We then looked at the cytokine profiling in the BAL fluid, and similar to what Adriana showed, we see significantly higher levels of IL-18, and really exclusively IL-18 in the BAL fluid, not other pro-inflammatory cytokines. A subset of these patients have high levels of these interferon-induced chemokines like CXCL9, but it's not universal. Then we looked at the gene expression profiles in the lung tissue itself. And what we found by comparing lung biopsy tissue from about a half dozen patients with systemic JIA and lung disease to control lungs, which were lungs that had been donated for the lung transplant program, but were not ultimately used to be given to somebody, is we saw an increase in a number of different gene sets. A number of HLA-related genes, which may relate to some of the work that Vivian's going to talk about in a moment, increase in a number of T cell activation genes, but a lot of interferon, and particularly interferon gamma pathway response genes. And so we've sort of put this together into a model that many of you have seen, where potentially the cytokine environment, the cytokine storm seen in systemic GIA, and particularly the MAS, which often occurs around the time lung disease is detected, can lead to changes in resident alveolar macrophages and recruitment of sort of a interferon gamma-driven Th1 response in the lungs. And then something about this then affects alveolar macrophages such that they're not able to functionally mature as they should, leading to this alveolar prognosis. Now, there's many unknowns in this, right? So what is the impact of IL-1 or IL-6 blocking biologics? Are there genetic factors, other environmental factors, or infections that play a role in this? I joke that anytime there's a model with this many arrows, you know it's wrong. But I think it lets us start asking some hypotheses. So a question that we've then been asking is, can we model pulmonary inflammation during MAS in mice? And the model that we've used is a model that was initially developed by Ed Behrens and has been used quite a bit by him, as well as Scott Canna and others, to model MAS, where sort of normal wild-type mice are given repeated treatments with an inflammatory agonist called CpG, which is a toll-like receptor agonist, which, if they're given 5 of these injections over about 10 days, develop a phenotype that looks a lot like the sort of subclinical MAS we see in many systemic JIA patients, with relative cytopenias, elevated ferritin, elevated systemic cytokines, liver and spleen inflammation. But then we wanted to look in the lungs to try to see what was happening. And what we saw was somewhat interesting. So in the lungs of mice that were had MAS induced with CpG treatment, we saw sort of a scattered but consistent lymphocyte-driven interstitial inflammation that was in sort of perivascular as well as in the alveolar septums, which is similar to the areas where we see that interstitial inflammation in systemic GIA lung disease. If we digest the lung tissue, we find that there's an increased number of CD3 and particularly CD4 T cells without really an increase in CD8 T cells. And then if we take those lung homogeneous induced cytokine profiles, we see a significant increase in interferon gamma and those interferon-induced chemokines, but not any other pro-inflammatory cytokines, which is in contrast to if you look in the periphery in the serum or the spleen, where you see everything going up in this. This is very specific for an interferon gamma-induced increase. We then wanted to look in the alveolar spaces and at the alveolar macrophages in this model. What we see is, while we don't see any increase in the number of alveolar macrophages, we see in the alveolar fluid a cytokine profile that looks very similar to what we see in the patients, which is high levels of IL-18, as well as an increase in CXCL9 and 10, a slight increase in interferon gamma as well. The alveolar macrophages themselves also show a interferon gamma-induced inflammatory phenotype, with increased expression of co-stimulus of MHC class 2, reflecting that classical activation. If we take those alveolar macrophages out of the lung, culture them in a dish, they're secreting those those interferon gamma-induced chemokines, and they show increased gene expression of interferon gamma-induced genes such as IL-12 and CXCL9. We then wanted to look at what happens over time in these mice as that MAS resolves, because again, many of the children we see with lung disease have sort of long-standing sort of what we call smoldering MAS, or subclinical disease activity prior to the emergence of lung disease. And if we looked at those lungs sort of 3 weeks after the induction of MAS, we actually saw more prominent inflammation in the lungs. We would see again this sort of lymphocytic interstitial inflammation, but it was much more prominent, including some sort of lymphoid aggregates. If we looked at the transcriptional response and what happens in the lung macrophages in that recovery period, what we see is that initially in acute MAS, we see activation of a pro-inflammatory gene expression signature, with the most activated gene pathway being that response to interferon gamma. However, when we compare that to those resolution phase macrophages, we see much more extensive transcriptional changes in resolution, nearly tenfold number of genes that are upregulated in resolution phase. And the upregulated genes largely reflect metabolic changes in those macrophages. Downregulated genes then sort of resolving that inflammation with decreased pathways involved in cytokine response and other immune processes. Skip this one because I think I'm getting a text that we're running out of time, because I want to show these last two slides where we then wanted to see what happens if we block interferon gamma. And we initially used an antibody, which was used initially again by Ed's initial paper in this model. So if we block MAS by concurrently administering an anti-interferon gamma monoclonal antibody, we see that a number of the features of MAS are reduced, particularly the anemia and the splenomegaly, although other cytopenias are less affected. The overall cytokine environment is overall decreased. If we look in the lungs, we then see a decreased response of those alveolar macrophages in their ability to secrete CXCL9, the CXCL9 levels in the BAL fluid, the surface markers of activation in those macrophages, as well as some of the gene expression changes. Finally, we took advantage of mice from my colleague Mike Jordan at Cincinnati, which are called MIG mice, which are macrophages in response insensitive to interferon gamma. They have a myeloid-specific defect in the interferon gamma receptor, so only the macrophages can't respond to interferon gamma. And when we look at those mice and induce MAS in that setting, we see a pretty similar phenotype to what we see in gamma blockade systemically, where we see much less splenomegaly, much less anemia. The overall cytokine environment is less pro-inflammatory, although we do still see some increases, including some increase in the ferritin level. If we look in the lungs, though, we see no increase in IL-18, we see no increase in CXCL9 and 10. And the macrophages themselves don't show any of those interferon-induced changes that we see in the wild-type setting. So suggesting that it's particularly the macrophage responses in the lungs to interferon gamma that are driving this inflammation. So I think that this also has relevance then to potentially how we're treating patients with lung disease. So as many of you know, and was discussed yesterday, there's an ongoing clinical trial of emapalumab or Gamifant for MAS and systemic JIA. Again, the overall results have been very promising. Some of those patients who received the medicine had lung disease. And what we observed was clinical improvement in their lung disease. So this is one of our patients here. On the right here, and I apologize, this is sort of left-handed, was their pre-Gamifant chest CT. On the left was sort of a similar cut post-Gamifant. And we see an overall reduction in the level of inflammation in the lungs, which is also associated with less need for respiratory support and less clinical symptoms. So overall, we think this is very promising as a way to potentially treat particularly severe exacerbations of the lung disease. Again, to sort of summarize, what we see in lung disease in systemic JIA is this alveolar PAP-type phenotype, which suggests to us dysfunctional alveolar macrophages. And we propose that a lot of that inflammation is driven by excessive interferon gamma activation, and this represents a potential target for the disease. I apologize for having to go through some of that data. I thought I'd have a little bit more time, but I want to make sure we have plenty of time for questions, as well as I'm hearing some other updates. But want to highlight folks in my lab who did this work, particularly Denny Gao, who did the mouse model.